Değerli hocalarım, kıymetli meslektaşlarım, bugün ikinci oturumunu açıyorum. Ben İskender Başar ve sevgili hocamız Berna Dilmaz'la bu oturumu yöneteceğiz. 3 konuşma var, daha sonra da arkasına uydu sempozyum gelecek. Ben davetleri için düzenleme kuruluna çok teşekkür ediyorum. Güzel ve verimli bir toplantının devamını diliyorum. İlk konuşmacımız Michel Odent, Londra'dan geliyorlar. Primal Health Research Center'dan geliyorlar. We are ready for your talk. Dear Michel, please. Konuları insan doğumunu özel yapan nedir?
Flow of people.
Sanıyorum giriş çıkışlar da tamamlandı. Kapıyı da, evet. Çok teşekkür ederim.
So, the door is closed. Good morning. After participating in this conference yesterday and this morning, I can notice many similarities with other conferences where I have been in other, we might say, emerging countries. Conferences in Latin America, conferences in China. There are similarities, and in all these countries, one of the dominant topics is how to control and even how to reduce the rate of cesarean section. This is a topic that came back many times yesterday and this morning. I'd like to suggest that as a primary objective to try to reduce the rate of cesarean section might be dangerous if it's the first objective. The risk might be more difficult birth by the vaginal route, increased need of pharmacological assistance, in particular drip of synthetic oxytocin. And we know almost nothing about possible long-term effect on the child of synthetic oxytocin. It has not really been studied. So what I suggest is that a reduced rate of C-section or a controlled rate of C-section should be a consequence, an effect of a better understanding of the physiological processes. And some of you probably remember that yesterday, when introducing the physiological perspective, I recall that physiologists rely to a great extent to animal experiment. And that's why it's so important to constantly keep in mind the differences between Homo sapiens, human beings, and the other mammals. We have similarities, but we have differences. And yesterday, we first focus on the structure of the human placenta. I don't want to go back to that in detail. We say some word about the hemochorionic human placenta and its huge capacity to transfer the IgG from maternal bloodstream to the fetal bloodstream before the birth. So a particularity of a human newborn baby is to be born with the same, roughly the same antibodies as the mother. So the main preoccupation in the neonatal period are not the same. Even if the early colostrum is beneficial, among humans, it's not absolutely vital. Well, for other mammals, the early colostrum is absolutely vital. A baby calf cannot survive without early colostrum. A human baby can survive. That's the main difference. It means that among humans, the main preoccupation is about the bacterial environment at birth. And when we introduce this issue, we realize the recent turning point about human birth from a bacteriological and therefore immunological perspective. Let's say, to simplify, I don't want to repeat what you said yesterday, that today, immediately after birth, the immune system of human babies is not educated, is not programmed anymore by a great diversity of microorganisms that are familiar to the mother. That's just an observation. I just want to add to what we developed a little more yesterday, that for that reason, today we are expecting a new generation of epidemiological studies based on a better understanding of human birth from bacteriological and immunological perspective. Until now, we are just expecting this new generation. However, I can mention already one study that already belongs to this framework. We have to be careful with one study, but we have to be interested in preliminary studies. It's a study from the Netherlands, from Holland, that has been possible in that country, for obvious reasons, at a time when the rates of home birth in that country were around 25%. It has been published in 2011 in the Journal of Allergology and Clinical Immunology. I summarize the result of this study. They looked at a population of children, all born by vaginal route. All of them were born by the vaginal route. But half of them at home, half of them in hospital. A study easy to do in the Netherlands. The main result is that the prevalence, the incidence, the prevalence of atopic diseases, allergic atopic diseases, and asthma was significantly lower among those born at home. I repeat, compare those with those born in a hospital by vaginal route. So forget this study, it's a preliminary study. It's just to emphasize that we have a better interest in the perinatal period from a bacteriological and immunological perspective. That will probably inspire a new generation of epidemiological studies. So that was just a note to recall that the human placenta is special. That's why there are limits in what we can learn from animal experiment. I prefer to go back to another aspect of my improvised presentation yesterday, because it was not originally in the program, and another way to emphasize the need to improve our understanding of the physiological processes. We must always start from a good understanding of physiology. Physiology studies what is universal, what is cross-cultural. It should be the basis, particularly for those involved in childbirth. And I want, in particular, to go back to what is a way to understand human nature in general. I want to go back to the concept of neocortical inhibition. The fact that today we start realizing that the powerful, huge, highly developed human neocortex is not always a tool at the service of physiological functions, but in some situations, it can obscure physiological functions. And to help understanding this concept, I find it useful not to jump directly on the issue of childbirth. This concept is better understood if you give some other examples of human physiological functions that are usually obscured, inhibited by neocortical activity. One of them is the sense of smell. We often wonder why the human sense of smell is so weak. I just mentioned briefly a study from Israel, an elegant study, easy to summarize, and I think you'll remember the result. If you drink a glass of wine, after that, your sense of smell is more acute, more precise, is more powerful. After drinking a glass of wine, what happens when you drink a glass of wine? You reduce neocortical control. You reduce neocortical activity. I'll give another example to clarify the meaning of this essential concept of neocortical inhibition by mentioning swimming behavior among humans. We know that immediately after birth, if a newborn baby is immersed, this baby does not panic, has perfectly coordinated swimming movements, keep eyes open, and go to the edge of the pool or the place where swim. But that will not last very long. After some weeks or some months, the same baby will get drowned in water. And that will be for a certain degree of neocortical development. There will be a neocortical inhibition. After that, a human being has to learn a technique to be able to swim. After that, the human beings will swim with a coordinated, organized, respiratory, and voluntary muscular movement. After this phase, where there will be a neocortical inhibition. And in fact, swimming behavior is often classified among human babies among the primitive reflexes that disappear for a certain degree of neocortical development. In medicine, this concept is only well known in general by psychiatrists. They know that in some mental diseases, there is a lack of neocortical control, so that the patient behaves in a way that is not culturally acceptable. However, there are some practitioners in human medicine who, in an empiric way, understand the concept of neocortical inhibition. Let's take the urologist. Imagine a urologist specialized in disease of the urinary tract. In front an elderly man who probably has a big prostate. The urologist will never ask the man, can you urinate in front of me? I want to know how powerful is your urine jet. The urologist will never do that. He knows that a man cannot urinate on demand in front of an observer. In an empiric way, he knows the concept of neocortical inhibition. So this introduction is to go back to what we said yesterday about human birth. The main reason for difficulties in human birth are not mechanical. That's why, occasionally, some women who are not special from a morphological point of view give birth to their first baby easily in 10 minutes, while others who are pretty similar from a morphological point of view need a C-section, a cesarean section, after 24 hours of hard labor. The main reason for difficulties for human birth are explained by the concept of neocortical inhibition. And the important point from a practical perspective, important point if we want to challenge thousands of years of cultural conditioning, thousands of years of socialization of childbirth, the important point is to understand the solution that nature found to make childbirth possible and even potentially easy in our species. A very simple solution. It's a reduced neocortical control, reduced neocortical activity. To give birth is not the business of the neocortex, it's the business of archaic, primitive brain structure. And I'm sure that some of you, even in 2016, understand this solution that nature found. Some of you still know that when a woman can give birth very quickly, easily, by herself, there is a time when she's as if cutting herself off from her world, forgetting what's happening around. She forgets what she learned and so on, her plan. She can behave in a way that usually is not culturally acceptable, swearing, screaming. She can find herself bizarre, unexpected postures, very often primitive quadrupedal posture. She's on the planet. That's the solution that nature found to make possible birth in our species. And that's a way to summarize in some words and to rediscover after thousands of years of socialization, what are the basic needs of a laboring woman? A laboring woman needs to be protected. When we think like physiologists, when you study like physiologists, an involuntary process, the key words are not helping, guiding, and so on. They are protecting against inhibitory factors. So a way to explain that a laboring woman needs to be protected, the key word is protected, against all possible stimulants of the neocortex. Starting, of course, with language. Language, when a woman is giving birth, is the main enemy, the main stimulant of the neocortex. Mentioning light at a time when we are learning that melatonin is an important hormone in human parturition, synergetic with oxytocin at many levels, but first at the neocortical level, acting on the receptors of GABA. When we understand that, we also understand that a laboring woman needs to be protected against light, particularly light rich in the blue spectrum. And to go back to all the stimulants of the neocortex, we can summarize basic need by saying that all attention-enhancing situation stimulate the neocortex. For example, feeling observed, somebody looking at you, stimulate the neocortex. Perception of a possible danger stimulate the neocortex. So this is a fast summary of how the physiological perspective can identify some inhibitory factors during the involuntary process of parturition. Another example of inhibitory situation is explained by the concept of adrenaline, oxytocin inhibition, antagonism. But the point is that the key word is always protection against inhibitory factor, challenging our cultural conditioning that women need help to give birth, support. It's a new way of thinking. It's a new paradigm. And this is what we need to, at the present time, to understand. This should be the priority. We must start by a better understanding of the physiological process. It can be dangerous to consider reduction of rate of C-section as a primary objective. We must start from what is basic. We must start from what is universal. We must start from the physiological perspective to challenge thousands of years of cultural conditioning and socialization of childbirth. This is...
Sir, excuse me. We done our time.
Yes,
yeah.
that's good news because...
Conclusions, please.
Because I have finished. Okay. So I've just finished. I tried to be fast. I just finished by saying that this is a reason for optimism. At a time when we are at the edge of the precipice, today, at a planetary level, the number of babies, the number of women who give birth by releasing a cocktail of hormone of love is insignificant. The number of babies that are immediately colonized by a great diversity of familial microbes is insignificant. Their immune system is not educated as usual. We're at the edge of the precipice. We have only one reason for optimism. It's the power of the physiological perspective to challenge thousands of years of cultural conditioning. Thank you.
We thank you, sir. Thank you very much for your interesting, well-depth. Please hold on a second. I'm coming for present you a document that we appreciate your company to this special event. Thank you. Değerli meslektaşlarım, ikinci konuşmaya geçeceğiz. Tartışmayı bu 3 konuşmanın sonunda alacağız. Daha sonra da uydu sempozyumumuzla devam edeceğiz.
Our next speaker is Mr. Robson, who's very famous for his Robson criteria. Bir sonraki konuşmacımız da bu Robson kriterleri biliyorsunuz Türkiye'de uygulanıyor. Onu dizayn eden Michel Robson ön gruplu klasifikasyonu sunacaklar. The floor is yours.
Thank you, and I'm privileged and delighted to be here. My first visit to Turkey. So these are the wrong slides. We just need to change the speakers. We changed the order. I hope my time hasn't started yet.
Just started.
Well,
Please.
yeah. Anyway, I should just introduce myself. I think anybody that talks about caesarean sections in this situation should declare their biases. I'm a full-time clinician. My academic activities is a hobby in my spare time. I'm a full-time clinician. I am favored towards a lower caesarean section rate rather than a higher caesarean section rate, but I think what's most important is that we have the best outcome for mother and baby. Thank you so much. And also, good information. And I just want to tell you the story about the 10 groups and try and summarize it all. I think in the workshop today, today, later on at 3 o'clock, we'll have more time to talk about it. And this is it started. You only know what you measure, and what you cannot measure must be made measurable. This is Galileo. This is the very basis of the 10 groups. And what I would add is not only that when we've got the information, it needs to be organized, it needs to be classified to make any sense of it. And I hope to persuade you today that the 10-group classification system is not just a classification of caesarean, but a completely different and new way of thinking. At the moment, it seems to me there are two competing philosophies in evidence-based medicine. There's this process-driven, which depends on randomized controlled trials, testing one process against another and deciding which is best. And there's the outcome-driven philosophy, which is perinatal audit, and which I'm really trying to explain about today, which looks at your results. Randomized controlled trials depend on relative outcomes over a limited period of time, while perinatal audit, as already has been emphasized today, concentrates on absolute outcomes over an indefinite period of time. And there's a very clear difference. Now, the sensible person would say, well, you need a bit of this and you need a bit of that. But I think the randomized controlled trial, and it would be controversial, that view, has gone too far without us being able to collect routine data collection. We can actually organize the most fantastic randomized controlled trials in the world and spend a lot of money, but nowhere in the world are we good enough to look at our results. Most of you will know a lot about trials, but very little about your own results. And it was Andrew Kotaska that emphasized, as randomized controls continue to ascend in the evolution of evidence-based medicine, we must recognize and respect the limitations when examining complex phenomena in heterogeneous population. This was about, in the BMJ, about the breach discussion, if you like, but it's very well worth reading from the point of view of epidemiological medicine. And women, healthcare professionals, and indeed governments are interested in safety and quality. And ultimately, safety and quality are related to outcome. And I would suggest it's outcome that's all the time stimulating and changing processes. Perinatal audit, there are challenges. It's not recognized as an entity, a specialist area, or even at all useful. Nobody considers looking at your results useful. It's a poor relation at the moment of randomized controlled trials. And as I said, collection of routine data is resource dependent, requiring total organizational commitment. And that's sometimes, strangely enough, difficult to do. Sports teams and other organizations know far more about their results than we do about laboring and delivering women. And lastly, and this is where I'm interested, no accepted classification or principles or even training programs teaching people how to look and interpret the results. And in theory, at least, it should be simpler to standardize measurement of outcomes rather than processes, because we all do things differently all over the world, and we just haven't managed, we've got to accept, after many years, identifying the ideal way of doing things. But if we did standardize measurement of outcome, and it's accepted, a greater degree of comparison, learning, and communication can and will take place. We've got all these women all over the world delivering babies, and what do we learn from the actual routine data? Absolutely nothing, I would argue. It may then be reasonably expected that processes would gradually merge over time. So I would suggest turning it around. We should embrace different ways of care, but we should concentrate on standardizing the way that we look at our results so greater learning and comparison can take place between delivery units. We all have got something to contribute, and I think we should take advantage of that. So we need to classify all perinatal outcome so these objective comparisons can be made of fetal and maternal events and outcomes over time in one unit and between units, both nationally and internationally. But to do that, we need a consistent, objective, and overarching structure, classification, within which we can examine all the fetal and maternal events and outcomes. And I think that's where we have been lacking. Some of the principles of perinatal audit, I think, are worth emphasizing. And overall rates of any events or outcomes, like cesarean section rates, are on their own meaningless. Not strictly true, but very, very small bit of all the information that is required. And I would suggest that no perinatal event or outcome, including cesarean section, should be considered, ever considered in isolation from other events, outcomes, and organizational issues. And there are many aspects to childbirth. We've just heard Michel Audin talk about the other aspects with the brain and other things. All of these things are important, but we've got to share our experiences. And the only way we can do that is by looking at the results in a standardized way. These are the things that I think should be included: perinatal morbidity and mortality, maternal morbidity and mortality, labor and delivery events and outcomes, even complaints, adverse incidents, medical legal cases. Maternal satisfaction is obviously ultimate, but also staff satisfaction. Staff satisfaction is crucial, because unless we create that environment that we just heard of from the previous speaker, by satisfied staff, by happy staff, by non-tired staff, we're not able to provide the right environment. So any classification has to be able to incorporate all of these things. And they must be able to incorporate other variables, not only perinatal, the criteria that I've just mentioned, the risk-benefit ratio criteria, but also age, BMI, fetal weight. The data collection must be aligned, organizational systems, and dare I say it, what time of day they deliver as well can be looked at. The classification must be able to incorporate all of those things. And the economics of childbirth, sadly, is an issue that we can't leave, and that's got to be part of the equation. So the ideal classification system has to be simple. It's got to be easy to implement. It's got to be useful and informative. Otherwise, nobody would use it. Robust in the sense that you don't want to change it every year or in different countries. And ideally self-validating. Self-validating means if you create a classification, you can, just by looking at the sizes and some of the incidence of events like cesarean sections, you can almost tell whether the data is good or not. It's got to be used everywhere, universal, and it shouldn't depend on a computer system. It should be just pencil and paper. It should be used everywhere in the world. In fact, the most important person should be able to understand it, and that's obviously the mother themselves. Prospectively determined, because if you want to look at your results, you may want to change results, so you have to know the groups prospectively. Clinically relevant, totally accountable, and it's got to be replicable. It's got to work every time you use it. The groups must be objectively at the top of the classification design, so we would all agree which ones would go into which group, and not subjectively defined. Indications for caesarean sections, we've got great difficulty in agreeing them. We always put 3 or 4 together just to be sure we're doing the right thing. And actually, when you try to classify that, it's not very good. But more importantly, it is after the event. And instead, you need an objective structure within which you can use the more subjective indications. It's got to be mutually exclusive. That means one woman in this certain situation will only go into one group and no more than one group, but also totally inclusive in that every woman would go into one group. And we would all agree which group it is. And it brings up a philosophy that you're removing the variables. You're removing the diagnosis of labor. You're moving oxytocin rates. You're moving rupture memory. You're moving all those variables that we can't agree. And you're creating groups of incidents of events and outcomes. And then you use that to compare to other units or delivery units. And you try and learn what do they do differently if you want to achieve what they are doing. And these are the criteria. Every woman is either a nulliparous woman, a multiparous woman without a scar, or a multiparous woman with a scar. It's prospective, it's objective, it's clinically relevant, it's what everybody looking after a woman in a delivery ward will think of. The category of the pregnancy, every pregnancy is either single cephalic, single breech, multiple pregnancy, single transverse or oblique lie. Simple, clinically relevant, and repeatable. Now the course is any woman will only deliver by going into spontaneous labor, being induced, or having a pre-labor caesarean section. That is the culmination of all the care we provide and what our advice is. But do you know what? In most countries, you wouldn't be able to even split women into those groups. And unless we know how often we're doing things, there will be no room for improvement. And lastly, the gestation of the delivery, again, another category which is useful to use. And when you have got good classification, there are only 3 reasons for any differences in sizes of the groups or events and outcomes in the group. First and foremost, it could be due to poor data quality. And most people who are starting doing the 10 groups for the first time will discover their data is not as good as they think it is. Secondly, if you've got good data quality, there'll be differences in significant epidemiological factors. That may be possible and may explain differences. But it's only when those 2 first are thought of that there will be, or you can put it down to an actual difference in practice. And the whole philosophy is based on the premise that all information will be more clinically relevant by stratifying them using the 10 groups, subgroups, or amalgamation of groups, but starting off with the 10 groups in homogeneous groups of women. 10 groups, why 10 groups? Well, 10 is a good number, it's a decimal number. There's enough groups to give you a little bit of explanation, but not too many, so people can't remember them. And these are the groups, and they've already been mentioned today, so I don't really want to go through them in detail. But they are very specifically lined up in that way. And it's also very important that we present the data in a standard way. So this is our data from Dublin, National Maternity Hospital. Unfortunately, I didn't have access to the Turkish data and the numbers in particular, because the numbers are important, but I would be very happy to look at it because it does need interpreting. The number of caesarean sections over the total number of deliveries in each group. And there are 3 very standard ways you should look at it. You should take the denominator of each group and put it over the denominator of the whole population, and you get the sizes of the group. The sizes of the group are a fingerprint of that particular population. And obviously you can apply it to a country, individual unit, a midwifery-led unit, or indeed private practice a cohort of deliveries. But the identification of the size of the groups must be looked at before you even touch the caesarean sections, not only to validate the data, but to sometimes explain key differences. You then look at the caesarean section rate within the groups, and lastly, you can work out the contribution of each group to the whole caesarean section rate by taking the numerator of each number of caesarean sections over the total denominator. And that takes into account the size of the group and also the caesarean section rate within the group. And classically, all over the world, it's groups 1, 2, and 5 that contribute to 2/3 of the caesarean section. So unless it's a unique population like China or a very rural population where all the mothers are second or third time mothers, that would be the standard contribution. I haven't got a lot of time to go into detail here, but we have a workshop. I just want to explain that it's only a starting point, the 10 group. It's criticized often because it doesn't do this or it doesn't do that. And you will see in the literature of a modified Robson group or a modified 10 groups or whatever, it is only the starting point where we can connect. And then it gives you an idea to look into different areas in more detail. And this very small article is worth reading, just summarizing it. There are obviously articles about how you achieve and maintain an appropriate caesarean section rate. Now, just look at the word appropriate. I mentioned appropriate. I might have my opinion on about appropriate rate in a certain population, but I don't want to get into arguments about whether it's high or low. I would have my view, and in some of the groups of women, especially spontaneous labor, it should be, I would argue, relatively lower. But that's when you split up inductions and pre-labor caesarean sections. This is another paper on quality assurance explaining again how the 10 groups are used. And you can see here the WHO have recently supported it, and they've come out with different versions in different languages, and I believe this is the Turkish version, although I don't understand it. But again, explaining the 10 groups. And the WHO have been very supportive in this sense, and they're also going to be producing a manual. And with the thanks of Anna Bertrand and Metin, who's played a huge part in this, this is something, for whatever reason, is being taken up by people more and more. It's not the solution, but it's the spark that gets people to discuss. And I'll come back to that in a moment. Again, a very clear WHO statement on caesarean section rates here, where they've analyzed their previous statements, and if you like, how I understand it, at least saying that we've not only got to look at caesarean sections, but here's a classification that you can look at other outcomes as well, whether it's the baby outcome, whether it's the placental histology, whether it's this, that. You can look at anything within that classification. And remember, when you've got 4 bits of information, all in the same classification, you can look at the section rate in one group, and you can look at the baby outcome. You can look at the oxytocin rate, you can look at the APGAR rate, you can look at everything within the classification. And particularly here, let's start to collect data uniformly, so that in the near future we'll be able to move our focus from the caesarean section at population level to monitoring and discussing caesarean sections and outcomes in each group. And I think that's a challenge to all of us to take part, because I emphasize again, we have all got something to contribute, whatever your caesarean section rate is and whatever your view on labor. That's a very important take-home message for you all today. FIGO have now endorsed it as well, and that involves the International Association of Midwives as well, again saying that it should be used and that we encourage everybody to make other information available on other outcomes, which is really important. It's not just caesarean section rate on its own. In summary, the 10 group is trying to simplify everything, to make clarity of thought and structure so everybody can think of it. Medical students and student midwives, when they first start, are now got some kind of structure to put all their information in. And what really is interesting to me going around, it is the people that are working at the front line that are really identifying with this system. Regression analyses and all of those things goes over the head, certainly of me and most people working on the front line. But this is something that everybody can have a part to play. They understand it because it's simple. And it stimulates interest. It stimulates argument and discussion. It stimulates education and understanding. And it encourages long-term commitment and responsibility because it's an ongoing thing. It's not a randomized trial over a month or so. It's a completely commitment to it. So I would argue the 10-group classification is not just a classification of cesarean. It's about a completely different way of thinking. It is only a starting point for more detailed analysis. Quality is related to a whole number of things. But outcomes are part of it, ultimately, if you ask any mother and family. And large, standardized, structured, prospective clinical databases are essential to analyze outcome. And routine data collection is going to be the first measure of the quality of perinatal care in any modern-day country. If your information is good, whatever your results, you should be reported it. Personally, I think an electronic patient record is the answer to this, and I think that that's why we in Ireland are just started to implement an electronic patient record, which is the same record everywhere in the country. So my last slide, Mr. Chairman, the biggest advance in 21st century in perinatal care is going to be as a result of better routine structured data collection, or at least that will give you the chance. Thank you very much.
Thank you very much, Mr. Robson, for your comprehensive presentation. I'll announce the workshop for today. Bugün saat 3'te Mr. Robson tarafından bu Robson kriterleriyle ilgili bir workshop düzenlenecek. Onu duyurmak istedim. Shall we move to your second speech, or you'll take a halt and...
I think we were going to have a gap in between.
Yes, yes. Then...
Otherwise, I can go on, but you might want to get fed up with me.
Okay, thank you very much.
So the next...
Yes, the next.
Me.
Hazır mı slaytlarınız?
Whose slides have you got next? Okay.
Your slides are ready.
I'm sorry, Rolf. Okay. So we move on to dystocia, ultimately the cause of all rising cesarean section rates. Now, you're going to be hearing a lot about dystocia today. And there's something about dystocia. It's an enigma. Does anybody understand what's an enigma? It's mysterious. It's difficult to explain, difficult to understand. But what we do know is it's probably the most common problem in labor and the biggest contributor, directly or indirectly, to the rising cesarean section rate. And I will try and show you why. Let's take dystocia. What can we agree on? We can agree on all the simple measures that there is an advantage of antenatal classes specific to your labor management. There is an advantage of people coming to visit the labor ward, look at the environment. There's an absolute advantage of friendly staff and comfortable environment, whether it's light or dark, as Michelle Donta said, may be important at all. There must be clear and consistent and honest advice from staff, mobilization and position, depending what the mother would prefer. One-to-one care, we do feel that that is important, so that there's somebody there looking after the mother all the time, and appropriate individualized relief of stress or pain. The etiology, I mean, traditionally we talk about the powers, we talk about the passenger, and we talk about the pelvis. But even the terminology, which I'll come back to in a moment, inefficient uterine action, dysfunctional labor, we use all these different terms. And in medicine, and just generally, when we use different terms, it's a very good sign that nobody knows what they're talking about. It's again, a mysterious subject. And it gets even more difficult when people use different terms in the literature, so you're not quite sure what they mean. The weight of the passenger, the malposition, malpresentation, and ultimately cephalopelvic distortion or obstructed labor may depend on the pelvis and may depend on the passenger, but in my view, it is actually very, very rare. The first cause is possibly the powers are the most important reason. What can't we agree on? We can't agree, as I've said, of a working definition or classification to aid the diagnosis, treatment, and continuous audit to assess whether cesarean section for dystocia can be reduced. And if we can't harness the ability to gather the information and learn from what is happening, it is very disappointing on the one hand, but it's also not helping the mothers to try and solve this problem. And I think the terminology is a big part of this problem. Difficult, abnormal, prolonged labor, failure to progress, failure to advance, labor rest. All of these terms are very, very difficult. And it really does mean that we don't understand the subject, and more important, we haven't put a structure to the subject to try and learn from whatever studies. Some use dystocia to describe the whole labor, and some only for a brief period of time. So if there's a lack of progress for 2 or 3 hours or 4 hours, that is thought to be dystocic according to different definitions. And then if you give or treat it in whatever way you do, maybe oxytocin, and they deliver normally, that gets confused with using dystocia as the whole labor itself. So there's no consistent definition as an indication for cesarean, and that's why when comparing results, it becomes a problem. I come from a hospital that practices a philosophy which is often misunderstood and misquoted, called active management of labor. But we describe dystocia as when delivery is by cesarean section or vaginally by the efforts of the doctor, when duration exceeds 12 hours or when some harmful effect befalls either mother or baby. And we record those figures in our annual clinical report. But the point I'm trying to say, it is important to have a definition and for everybody to be clear about the definition. General management of labor, and you hear a lot about this today, the contentious issues is how you diagnose labor, the timing of artificial rupture of the membranes, and indeed, not only whether you need oxytocin, but how often you use it, the timing and the regimen of oxytocin used. Less contentious issues in which we still differ and may affect the incidence of dystocia is the way we monitor the baby. The incidence and type of epidural is thought to influence it. But more than that, it's the way we look after the mother, the way we support her. And in some units, that may not always be possible for lack of staff or other organizational reasons. And then there are things that we probably do not disagree on, but we should be more consistent in our management and analysis. In particular, the whole difference between nulliparous women versus multiparous women plus or minus a scar. Dystocia is primarily a problem of nulliparous women. Yet you see so many papers in the literature which have mixed up nulliparous and multiparous women into one paper and talk about dystocia. Those papers, to me, personally, are meaningless. And you've got to separate it out. And you've also got to separate it out into spontaneous and induced labor, never mind single cephalic versus breaches and all the other twins and other obstetrical abnormalities like breaches. And premature labor is a completely different thing, where dystocia, in its simplest entity at least, doesn't exist and shouldn't exist. But it is related. Now, all of these categories you will immediately recognize form the basis of the 10 groups. And that's why dystocia should never be spoken outside in an entirety, but should be looked at within each group of the 10 groups, or indeed any of the subgroups itself. So my argument is that whatever your views on however you do, a bit like I said before, embrace different ways of management, but actually try and collect the information in a standardized way. We need an objective classification of indications for cesarean in labor. Oxytocin needs to be part of it. Why? Because it's the most commonest drug that people use to treat dystocia. Now, I'm not going to get into a discussion of what the incidence is. We can discuss that at some other time. But the fact is, oxytocin is a dangerous drug. And as has already been mentioned by the previous speaker, the epigenetics of oxytocin and what it may do in terms of genetic is still up there for discussion. But the fact is, we still use it. And I think most people in the audience would agree that if you can get away with lower doses rather than higher, lower incidence rather than higher incidence, that's important. So oxytocin needs to be part of the classification. And this is the important bit. The classification can be used irrespective of the type of management. And the thing about classifications, if we want to stick to the principles about learning from each other, we don't want to rule people out just because they manage labor differently to us. We want to be able to analyze it in the same way, and then if they have better outcomes or better quality or whatever you want to talk about, because you've got different results, you will go to them and say, what is it you do differently? What can I learn from you? Why are your mother so happy? Why, etc. So we need a classification that takes out the variables of how you diagnose labor, how you monitor the baby, how you assess and treat poor progress, when you rupture membranes, the oxytocin regimen and epidurals, because we cannot agree on those, and we won't. And we mustn't let that hold us back on trying to progress care. And with this classification, we've got to order other events and outcomes at the same time. So when you look at a cesarean section order, first of all, you've got to know and understand your own results. And the most fundamental thing, if you're looking at cesarean section rates, is if, and I'm just taking our own figures here, is of the overall cesarean, how many are pre-labor and how many are after spontaneous and induced? And if you don't know that, you can't begin, because it's a totally different organizational concept if you're trying to, let's just say, affect a cesarean section rate if all of them are done before labor as opposed to after spontaneous or induced labor. Now remember what I'm saying. I'm not here to argue about reducing or increasing or whatever about section rates, but what I'm saying is, and what I'm trying to get over, is a way of logical thinking. So in our unit, our big problem seems to be at the moment, if you talk about cesarean section, is pre-labor cesarean sections. And as a chair or a department, I was master of the National Maternity Hospital for 7 years. Organizationally, you need completely different resolutions to deal with that as opposed to after spontaneous or induced labor. The 10 groups undoubtedly helps. And you can see here in this hospital, which is our hospital, group 1 and group 3, which is nearly 50% of the population, we have very low cesarean section rates and spontaneous labor. And again, it's group 1 that is the most important contributor. But group 1 and 2, it is dystocia that is the biggest contribution. And remember, if they have one cesarean section, they go into group 5, which obviously has a high cesarean section rate. So if you've got a high incidence of dystocia in your first labor and delivery, you will automatically have a higher cesarean section rate with women with a previous cesarean section. Because however good you are, if you reduce the section rate in VBACs further and further down, you will always have some risks of other problems happening in labor, and that's been well shown. But I do want to point out that the other contributions of all the groups are very, very marginal. And if you had a bad experience, even if you've had a vaginal delivery the first time and a very long labor related to some dystocic element or a long time to deliver, most women asking for cesarean section for maternal request are not women in their first pregnancy. They're usually women who have had a very bad experience in their first pregnancy and just don't want a cesarean section the second time. And usually that bad experience is because of long labors, and that's where we get back to dystocia again. There are some women that then tell their little sisters what a bad experience they had, and their little sisters then come back and say, we want a cesarean section. Most women don't choose a cesarean section because they want one. They are often saying no to the alternative. And that's where it's so important to look after women physically and emotionally well in their first pregnancy. A classification is more helpful than indication, and this is what I'm going to try and show you now. Just want to speak about pre-labor sections first. Ideally, we should divide it up into fetal or maternal, and to a certain extent, be honest about no medical reason. And what I mean by no medical reason or maternal request is a situation where a woman comes to you and asks for a cesarean section where you normally wouldn't have said you must have a cesarean section. And I really do think that most women want to deliver their baby. Sorry, not most women. All women want to deliver the baby in the best and safest way for them and their baby. And if they choose something that we disagree with, either they could be right and we could be wrong, or the care is not what we think it is. We are quoting randomized controlled trial from everywhere else in the world rather than looking at our own results. Or there's not enough information to persuade them or make them understand for a certain choice. And it becomes our responsibility to provide that information. So getting back to dystocia and after spontaneous and induced labor, in classifying labors and why they end up with a cesarean section, I think there's 3 questions to ask. Is the indication for cesarean section fetal or something called dystocia? And fetal means no oxytocin. Has cervical dilatation been more or less than 1 centimeter an hour? Now that's a purely arbitrary division, and you can make subdivisions of that. But we're trying to divide labors up into those that have very efficient uterine action and then go across and get obstructed, or labors, whatever you do, just progress very slowly. And I've used 1 centimeter an hour less. And then was oxytocin used? So this is an example of what I mean by labors that have got inefficient uterine action, that go straight across. And these are labors that are efficient uterine action and then go straight across after they get to nearly at least full dilatation, the old secondary arrest, even after oxytocin. So I would put to you, there are 2 types of labors that end up with cesarean section. Labors that go very, very slowly in cervical dilatation, and labors that progress quickly with cervical dilatation, but then get stuck. And this is the classification that we've used for about 10 years now, and we're going to do some studies in Norway to apply it to a national population, hopefully. But it's really actually saying that in labor, you either deliver by cesarean section for fetal, whatever that reason is, CTG, meconium, bleeding, but the difference is that you haven't used oxytocin, okay? So no oxytocin. Or otherwise, there's some element of dystocia, which is a term which describes lack of progress within whatever time frame a unit has set. And that lack of progress can either be inefficient uterine action or efficient uterine action and going across. And efficient uterine action can be divided up into inefficient uterine action, poor response. Those are the women that in whatever you decide in your unit, you have given oxytocin at whatever dose and it still goes across. You've got it up to the maximum dose, but it still goes across. I think we would all recognize those labors. The labors that have poor progress that you need to treat, and you treat with oxytocin at whatever time point you say, but you're unable to treat it to the dose that your regimen is in your unit because it continually overcontracts the uterus. And because there are clear safety margins in terms of tachysystole, there is just, in the end, you end up by delivering by cesarean. But again, certainly most of us would recognize that type of labor. And then the labor where you have inefficient uterine action, you have a dystocic element to it for incoordinate uterine action or inefficient uterine action. You give oxytocin, but the baby isn't able to tolerate it. And its inability to treat fetal intolerance. Now this is a very different group to this one up here. This one is fetal indication with no oxytocin, and this is one where you've got a fetal indication, but only as a result of your treatment of dystocia. And I think most units don't separate this from that. So they give oxytocin, it causes fetal intolerance, and you put it down as fetal intolerance. There's nothing wrong with the baby, and when you stop the oxytocin, either because you're giving too high a dose or too quickly, or in that particular labor you can't get it at above a certain rate, then the baby is fine, but you still have inefficient uterine action. And then lastly, you have inefficient uterine action, and you have no oxytocin given. Now, with us, we always would give oxytocin in the first-time mother, but there are women with a previous scar that we would sometimes deliver for inefficient uterine action, but no oxytocin. Now, once you start collecting data using this classification, you will be able to look at your results. And this has been published in a paper that we published in the American Journal recently, looking at amniotic fluid lactate at the same time. And these variables are kept completely out of the classification. And what you do is you look at your results, and when you compare with a different unit who uses maybe a different oxytocin regimen, a different diagnosis of labor, you can compare and learn from each other. These are our results, and 8.7 in group 1 is probably, there aren't many units that have a lower cesarean section rate in spontaneous labor and first-time mother, but you can see our biggest group is dystocia, inefficient uterine action, inability to treat, fetal intolerance. That doesn't mean to say we're causing more problems to the baby by giving oxytocin. It means that we get to a certain level in oxytocin concentration, and we can't go any higher. So ordered of dystocia, if you classify your cesarean sections according to the classification I've just shown, you've also got to look at the rupture membranes, the oxytocin rates, the fetal monitoring rate, the cesarean section rates, the induction rate, the PPH rate, length of labor, incidence of one-to-one care, patient satisfaction, absolutely crucial, both physical and emotional, and also neonatal outcomes. And all of these points are related to dystocia. So whenever you see anybody talking about a certain type of management in relation to dystocia, what I do is I just want to know their results. If their results are good, I get very interested and see what they do, and maybe we can learn from them. If the results aren't so good, then obviously I stick to what we do. But finishing off, understanding the true contribution of dystocia to the cesarean section rate will not improve until we audit labor events and outcomes in a standardized way and understand their relationships. And in labor or after induction, they're the key issues about classifying which women are sectioned and for what reasons. You can have all the subjective data in the world, like age 41 and this and that and whatever, but there's subjective data. Most women will get sectioned either for dystocia, either as a result of the dystocia or the treatment of dystocia. And the two types of dystocia are when it goes just across and it goes nowhere, or it's got efficient uterine action, goes up and goes across, and that's where it's CPD or persistent malposition. Thank you, Mr. Chairman. I think I've certainly overstayed my time. Thank you all for listening, and hope to see you at the workshop.
Mr. Robson, we'd like to present your certificate.
Değerli katılımcılar, bu oturumun ilk bölümünün 3. konuşmasını yapmak üzere Ralf Skajerven'i kürsüye davet ediyorum. Kendileri Norveç Bergen'den katılıyorlar. Bergen Üniversitesi'de görevliler. Konuşmaları uzun vadede anne ölümlerinin gebelik sonuçları ile ilişkisi. Yes, Ralf, we are ready for your talk. Thank you for coming. Yeah. Okay, thank you.
Thank you, Mr. Chairman. Thank you so much for inviting me. It's really an honor to come to this fantastic country and this really nice city. I had to admit I had trouble coming into the country because I didn't know I needed a visa coming from Norway, but I did. So I had to go back from the front of the queue and all the way back, but I managed. This is Bergen for you. It's the west coast of Norway. Of course, you have all been there, and you have to come back. It's the gateway to the fjords. I guess you have heard about some fjords in Norway. So, as it was announced, I'm from University of Bergen, and I also have this link to National Institute of Public Health, which is basically in Oslo, but we have a unit for registries in Bergen, and as it has developed, we have now basically all the key registries in Norway, we have them in Bergen. So we have the birth registry in Bergen, and we have the death registry in Bergen, and we have a lot of the registries in between. So it's a fun place to be and to do research. So this talk will be on maternal mortality, but not as you have listened to before today. It is long-term maternal mortality, which is basically like 20 years after pregnancy. So it's not immediately 42 days mortality. Most of the focus on maternal mortality and pregnancy complications has been on preeclampsia. And there has been a lot of review papers on preeclampsia and cardiovascular death. This, for instance, from 2007, where the conclusion is that there is a hazard, excess hazard, around 2.2 after heart disease and 1.8 after stroke, related to stroke. But the thing is that almost all the studies have been focusing first pregnancy only. And therefore, I am tempted to say that this research has very little value. And I will, during this talk, hopefully convince you about that. So we'll see how that goes. Please address me after this talk and tomorrow. I would love to talk to you about these issues. A very early publication of maternal mortality, long-term maternal mortality, was done by Chesley. He basically did all these data himself. So he followed the women for 40 years, and he published in 76, and then in year 2000 he had follow-up. So basically a 60-year study. It's really impressive. And here you see that it's not basically primiparous, but it's much more multiparous. That Chesley report, and that is giving you the well. So I want for you to think of these two questions. In reproductive epidemiology, what is the study unit? And especially when you look at maternal mortality, long-term maternal mortality in relation to pregnancy outcome, is it then a question of the child, or is it a question of the mother? I would, of course, say it's a question of the mother, not the child. So I would recommend, instead of looking at the outcome at first birth, you need to look at the women's total reproduction, not their first pregnancy. In Norway, maybe I have a slide on that. No. In Norway, we have better reproduction than in Italy for certain. So 85% of women that have their first pregnancy later have a second or third pregnancy. So that leaves only 15% back for women who have one pregnancy. And one pregnancy is absolutely okay to study, but only when it's their lifetime reproduction. So in recent years, actually, these publications are within since 2012. So we have been working a lot on these issues. And as you see on the list, it's a lot of preeclampsia focus. So I will show you not all these things, but basically the principle. I want to show you the principle. So this paper was published in 2012, and it got a strange title, so no one understands what we are doing, but I'll show you what it is about. It says cardiovascular mortality after preeclampsia in one-child mothers, but of course we are looking also at two-child mothers. And what we basically find is that there is one group of mothers that have high risk of mortality in relation to their pregnancy outcome, and that is the women with only one pregnancy. And we have a very fortunate setting in Norway. We have 50 years of continuous population-based registry, and we have so we have basically then for the first mothers in the first years, we have 50-year follow-up. Of course, we don't have follow-up for 50 years for all the mothers, but we have long enough to be pretty sure that women will never have more than that one pregnancy when we do the analysis. And as you can see, the risk is hardly there after either preterm or term preeclampsia if the woman after the preeclamptic pregnancy in first pregnancy have another child. And so if you look at more in details on the tables, you see that preterm preeclampsia has a 10-fold, almost 11-fold risk. If the women have one more child, it's 2.3, so 1/4 of the risk for the one-child mothers. And also in connection with term preeclampsia, 4.1 and 1.5, really a huge drop in risk. And this is good news for preeclampsia and long-term survival, because at least in Norway, we don't have women with only one child. So it's only 15% of the preeclamptic pregnancies that really are at risk for early death. It's not 100%. So, and it's even better if you look at total mortality. If you die, then you die. It doesn't matter so much for the mother what she died of. So she either die or she don't die. And if you see down here, if you have 2 or more pregnancies again, we are down here, and actually you have lower risk in relation to preeclampsia than other women, and certainly lower risk than those with only one child. So in total, you don't die of preeclampsia. In total mortality, you die if you only have one child, and we need to understand what is the cause for having one child, when the norm in the society is 2 or 3 children. We also have looked at paternal mortality, and of course we don't get any effect like in the mothers. This is CVD mortality again, but if the father only have one child, we have the same elevated risk, a little lower than for the mothers. I can drop this. So we have analytical strategies for all the papers we have done in these years. Not only the first birth, but the complete reproduction of women. 85%, I've said, So, and then in addition to ensure that you have the reproduction of the women, you need to investigate what is needed to ensure that you have the complete reproduction. And we have found that in Norway, 95% of women have their reproduction during 7 years. And so this is a busy slide, but I think it's easy to understand. So then you have preeclampsia in later pregnancies, and then it is certainly more complicated, but it's doable. And what you see is basically a follow-up to what you find with if you have one child or 2 or more children and preeclampsia in the first. If you have preeclampsia in later pregnancies, then you are at risk again. And so preterm matters, when you have your preeclampsia matters, and as the same as Chesley found, if you have preeclampsia later, not in first, and you have more pregnancies, then it's worse for you in terms of survival that the preeclamptic condition is in the later pregnancy rather than in the first pregnancy. So that's the total story this busy slide tell you. And I've signed that you can get these slides, so you can look at these later on. And exactly the same principle we have done for perinatal survival. So of course it's natural to think that there is a link between survival of the child and survival of the mother. Again, it seems to be a question of what happened next. So you have a child in the first pregnancy, the child died, and you have no more pregnancies. That's a tough one. And it's not difficult to think of the scenario why there is higher risk for those women than those that go on. And as you see, as soon as you have another child after the loss, you have a lower maternal mortality. And also, if the loss is later, the risk is higher than if the risk is in the first pregnancy. And that applies to 2 pregnancies, 3 pregnancies, and 4 pregnancies. And we have also looked at multiple losses. Multiple losses is, of course, not good, but it is better to have more surviving kids among the total reproduction than the stopping. So the stopping rule, why do you die not having more pregnancies? And if you think of the situation where you have one pregnancy and the child dies, of course the mother and father don't have any surviving children. And we know in general that having children is good for men and women for their own health. And so it's an obvious thing. But these issues have not been addressed in previous papers. They are focusing loss in first pregnancy, and then they conclude for the whole reproductive period, which is not right. So briefly about our registry. So we started in 1967. We are the longest lasting population-based birth registry in the world. So we have 50-year anniversary this year, so it's a good year to have talks like this. We have 3 million births in the registry during these 50 years. Of course, you have 3 million births a year in this country, but we creep up there. Just keep on for 50 years, then we are as large as you are. But the good thing is in Norway is that we have personal identifiers for mothers and fathers and children. And with those, you can imagine we can do all kind of, with modern computers, we can do all kind of linkages between birth and death, cancer registry, education registries, and so on. And even better, we can do these internal linkages that we have used a lot, ending up with siblings and generations. And to do these studies I'm talking about now, it's basically finding the siblings and mothers and looking at her survival, giving her overall reproduction. So quickly doing some other results, deviating from a lot of the literature. There is an English, very well-known English guy called George Davis Smith. He has published 10 papers on childbirth rate and maternal mortality, and he assumes a linear relation between birth weight and mortality. And as you can see, at least in Norway, we have nothing like linearity. We have a linearity if you use absolute birth weight, but only to a certain stage. So we found that set scores for birth weight by gestational age is a better way to deal with this. And then as soon as you go beyond the mean in the population, the maternal mortality goes up. And what is that? That is, if you look at the next pregnancy, you will see that those with a large baby will more likely have diabetes in the next pregnancy than if the child is smaller. They also looked at the effect of preterm in general and whether the pregnancy was induced or was spontaneously delivered. And to my surprise, the induced show clearly higher maternal mortality than the spontaneous. And it does that for all the gestational age categories with some not easy to understand small jump there. But that's what we got. So I will finish up with some other issues that we can to find out what is going on. What are the causal mechanisms between, for instance, preeclampsia and maternal mortality? So do preeclampsia do women get preeclampsia because they have a heart condition, or is it the other way around? That's a very important question to answer. And how do you do that? Well, what we can do, again, using our linking possibilities, we can find the unaffected sisters of mothers with preeclampsia. And then we look at the long-term risk for CVD risk for the unaffected sister who did not have preeclampsia. So we are doing that for cardiovascular death and other type of death now, but we have already published, actually in New England and this other paper, the same story for end-stage renal disease, and you know
Sir,
that...
excuse me.
Yeah. 2
minutes left.
Yeah, I'm there.
Thank you.
So the end-stage renal disease is something that is strongly related to preeclampsia. Yeah. So we can find the unaffected sister using the population data we have. And so what's the conclusion? The conclusion is that after preeclampsia, there's a six-fold risk for end-stage renal disease. For the unaffected sister, there is no effect. And that, to us, indicates that preeclampsia is doing harm to mothers. And so if you can avoid preeclampsia, then she will less likely die of preeclampsia. Yeah. So I will go to my final comment, and that is that there's too much focus on one pregnancy complication in a study. So you look at preeclampsia, or you look at preterm, or you look at perinatal death, or you look at gestational diabetes. The thing is that all these factors are linked. So if I go from within the same pregnancy, or if I go from the first pregnancy to the second pregnancy of the same mother, these factors are interrelated. So, and this has been, it's not a new idea. So Robert Romero has described this as this GOS syndrome, and, but he is thinking on care of the baby, and we want to apply this GOS on maternal mortality, and I think that will be interesting. So far, this is what I've got. This is the hazard ratio for maternal CVD death for women with 1, 2, 3, 4 pregnancies, and by the number of these factors within one pregnancy, within the sum of the 2 pregnancies, or the sum of the 3 and 4 pregnancies. And obviously, the more you have, the more you are at risk for dying. And I think this is a way to go. Finally, preeclampsia and paradoxes. Smoking, you know, reduce the risk for preeclampsia. Breast cancer is reduced 20 to 30% by preeclampsia. Lung cancer is reduced 50 to 60% by preeclampsia. And that's hard to tackle because you think that preeclampsia is a risk. Actually, preeclampsia is an indicator that this mother has not been smoking. So it's very complicated. And that means that the twofold risk that you find in the population for preeclampsia and CVD mortality is a reduced estimate. If you could adjust for smoking, the risk would be much higher. Indicated by this, no one would argue with me that lung cancer is reduced for preeclampsia because the mothers, they are not smokers. But breast cancer, they would debate, I'm sure. Thank you.
We thank you. Great talk. Please hold on a second. We will present you a certificate. Değerli meslektaşlarım, zamanımızı bir parça açtık. Biraz daha verimli kullanmak adına şu ana kadar olan, oturumun başından şu ana kadar olan konuşmalarla ilgili soru, tartışma, katkıda bulunmak isteyen arkadaşım var mı? Yok ise müsaadenizle ikinci bölüme geçeceğim. No questions, comments? Yeah. Okay. Yeah.
Rolf, in the 15% of first-time mothers that died early, did it make a difference what age they had the pregnancy at? So if they had it at 20 and didn't have any more babies, or whether they had it at 40 and had no babies? No, I'm just asking if a mother only has one baby, did it make a difference to her death rate when compared to the multiparous women, whether she had the baby early at 20 and had no more children, or whether she had it at 40?
Yeah, it's a good question.
Did it show any difference?
It's a good question, and we have looked at that, and it's not surprise to you that if you are like 40 with your first pregnancy, you don't die of having one pregnancy. It's when you're 20 and only have one pregnancy, you have the high risk. Yeah. So the contrary than what you biologically will think. But you should never forget the social factors around pregnancies. They are, in this context, stronger than the biological.
So at 20.
Yeah.
20 yaştaki komplike gebeliğin kardiyovasküler dezavantaj, ölüm mortalite oranları açısından daha riskli olduğunu söyleyebiliyor. Sinan Hocam buyurun. Buyurun mikrofon lütfen. Nasıl arzu ederseniz hocam. Önce Türkçesini söyleyin isterseniz arkadaşlarımız için.
Benim bir katkım ve sorum olacak. Burada preeklamsiden ziyade preeklamsinin altında yatan faktörler bence önemli. Bu sonuçlar çok güzel, ilgimizi çekti. Ama baktığınız zaman preeklamsiye neden olan faktörlere, risk faktörlerine baktığınız zaman bunlarda endotel hasarı yani damar problemine neden olan ve trombofili ile giden bazı polimorfizmlerin olması, bunlarda bazı enzim yolak bozukluklarının olması, yine kronik enflamatuar hastalıklar. Bunlar Behçet olabilir, Kron hastalığı olabilir, ülseratif kolit olabilir ve de bu grup hastaların yanı sıra otoimmün hastalıklar. Biliyoruz ki bu saydıklarımda daha fazla preeklamsi görülüyor. Dolayısıyla preeklamsiden ziyade preeklamsinin altında yatan etiyolojik nedenler bence probleme neden olmakta. Onun için ben Norveç registrisinde bunlarla ilgili bilgi var mı onu öğrenmek istiyorum. Do you want me to translate it? I have a question. Yeah, you do it. My question is.
Şimdi katkınızı zaten yaptınız. Sadece soruyu yönlendirin isterseniz. Norveç Registresi ile ilgili. Buyurun.
Do you have any information in your registry related to the etiology behind preeclampsia? For example, some enzyme pathway disorders, polymorphisms, especially going together with thrombophilia, and chronic inflammatory diseases such as ulcerative colitis, Behçet's disease, Crohn's disease, and autoimmune disorders, because we know that these disorders, when we have these disorders, we have more frequent preeclampsia. And then those etiologic factors might be the reason of increased cardiovascular complications in later life.
Excuse me, my understanding is, have you used stratification of patients? Stratification. You know, I mean, hypothyroids, it's just example. Autoimmune disease population, or, you know, okay.
I can have a quick answer on that, and that is the presentations are based on registry data. And in the registration, we have always ICD-coded all the medical complications that is written down by the doctor or the midwife. So we have those kind of details when it's written down, but I'm pretty sure that it's not as complete that you would like it to be. But we have some of these things. I'm doing kind of the first work. It's more, I'm an epidemiologist, not a clinician, so I am concerned for the method. And when I started this 2012 BMJ paper, my intention was to look at how much more do women die when they have replications of preeclampsia. That was my idea. And I was so astounded that they are not the women that die the most. It's those who stop. And actually, those who have only one child without preeclampsia, they die. So therefore, the whole project changed into this SIBS and the value of more pregnancy for long survival.
Çağrı buyurun. Bir sorumuz daha var. Soru mu katkı mı?
Ben Sinan hocamızın sorusuna hem açıklık getirmek için hem de Rove'la ilgili bir şey söylemek istiyorum. Hepimiz Mr. Robson'u ve Mr. Odent'i çok yakından tanıyoruz ama bundan 2 sene önce ben Ankara Üniversitesi'nde epidemiyoloji yaparken kendisinin yayınlarına baktım. İnanılmaz bir epidemiyolog ama hep kadın doğumla ilgili ve çok kısaca Norway Birth Registry diye bir sistemleri var hocam. Orada her kişiye bir unique number veriyorlar. Dolayısıyla 50-60 sene o hastaları izleyebiliyorlar. Dolayısıyla birçok data, onun içerisinde data... Hocam çok bir şey söyleyeceğim.
Edersin. Bu 50 senedir sabit kodlama sistemi yapabiliyorlar mı?
Yapıyorlar hocam. Onunla ilgili 10 sayfalık bir karşılaştırma önerisi yazdım ben aslında. Sağlık Bakanlığımıza da ilettim. Şöyle bir tane örnek vermek istiyorum. Ben kendisinin yaptığı çalışmadan. Biz biliyoruz ki nulliparlarda preeklamsi riski yükseliyor. Yaptığı bir çalışma var. Eğer bir anne evlenmiş bir babayla ve bir çocuk yapmış, ayrılmış, başka bir eşle evlenmiş, acaba yani baba faktörü var mı preeklamsinin artmasında diye. Dolayısıyla ikinci eşinden olan ilk çocuğunda preeklamsi artıyor mu diye bakmış. Tabii buradan 1 milyon kişi üstünde yapılmış çalışmalar. Yani ben bütün meslektaşlarıma Rawls'un çok mükemmel çalışmalarını takip etmesini öneririm. Çok teşekkür ediyorum.
Teşekkür ediyorum. Bir dakika. Evet buyurun.
Burada yanlış anlaşılma var. Aynı şeyi konuşmuyoruz. Ben de 1,5 yıl İsveç'te, Stockholm'da kaldım. Onların şeylerini gayet iyi biliyorum. Benim söylediğim, buradaki problem preeklamsinin kendisinin olmadığı. What I'm saying that the problem is not preeclampsia itself, but the problem is the risk factors behind preeclampsia. This is what I'm saying.
Yeah, and actually I'm saying the same. I want you to find out why one child mothers with preeclampsia is dying more than those that go on for other pregnancies. So is there something with their preeclamptic condition, or is it some of these factors you have mentioned? So now you know that one child mothers, at least in Norway, die more if they have preeclampsia than those who have 3 or 4 more pregnancies. So what's the difference between those two mothers? That's the sense. And I'm working at the registry. You're at the clinic, so you have to answer that. Now I've given you the problem to solve.
The answer is existing in your slides. You have described 7 items. 5 of them is very much related to autoimmune disorders, some polymorphisms related to thrombophilia and enzyme pathway disorders. The 7 risk factors: intrauterine growth retardation, preeclampsia, ablatio placenta, and
Gestational diabetes.
yeah, 2 of them, gestational diabetes and the obesity, okay, belonging to diabetes mellitus. Again, it's a vessel problem. It's a vascular problem. So when you look at the 7 items, they are all vascular problems. And when you look at the etiology behind those complications, you will see the same disorders.
Yeah. Okay. So I have a slide for you showing that you're wrong. Should I show that?
Sure. Okay. Yeah, we will take care of it. Okay.
Next. So this is showing 3 factors simultaneously on the way to this GOS thing. So here you see preeclampsia, yes or no. You have gestation age in 3 categories, and then you have large or small fetus. And it turns out that for the mother, it's better to have a small child that died than to have a large fetus. But for the child, of course, for the child, it's not good to be small and be preterm and have preeclampsia. But it's even worse to be small and not have preeclampsia. But for the mother, the worst risk is to have a large baby when you have preeclampsia and is preterm.
Preterm.
So what we do when we do science is we think of the child and the mother in parallel. But a lot of my experience with working with maternal mortality is that maternal mortality and for instance, perinatal mortality are not following each other necessarily. And you can imagine, so for a woman with diabetes, the child would be happy with that diabetic condition because it will not be small and growth retarded. And that's exactly what's happening here. The mother has diabetes, so the child is big and survives. And that's good for the child, but it's not good for the mother. And the question is, who is the cause? And there's this David Haig, he claims that there is a battle between the mother and the child. And maybe that's what you see here. So, sorry.
No. Hocam burada keselim. Thank you. Thank you for your explanation. Okay, thank you.